Next panel is discussing resources for children with the most complex needs. We know that often kids that board the longest or who have the longest wait tend to be the most complex, need the most complex care. Each of these panelists lead work at their respective organizations to break down the barriers to accessing care for these children. Marisol Garcia directs the work of the Mental Health Advocacy Program for Kids, which serves families whose youth are in need of access to appropriate mental health services and are court-involved or at risk of court-ordered involvement. Dr. Assaad Sayah is the CEO of the Cambridge Health Alliance, where he has previously served as Chief Medical Officer and Chief of Emergency Medicine and a Senior Vice President of Primary Care. Melissa Threadgill is the Director of Strategic Innovation at the Massachusetts Office of the Child Advocate. I'd also like to introduce Amara Anosike, and close enough, sorry, Director of Behavioral Health and Advocacy at the Boston Children's Hospital, who will be monitoring this panel.
Thank you so much, Jackie. I'm so honored to be here today among many friends to be moderating this very esteemed panel on a topic that is very near and dear to my heart. In my role at Boston Children's Hospital, where we, is that a bird? I don't know what that is. Okay. I was gonna say, we've been seeing turkeys in Central Square. So at Boston Children's Hospital, this is a very important, near and dear topic to my heart. At Boston Children's Hospital, we see about a third of the state's behavioral health boarders, and often the most complex. Kids with co-occurring medical conditions, kids with co-occurring autism, kids with multiple state agencies involved, and oftentimes you'll find, yes, there are a lack of beds, but the barriers, the silos to accessing maybe a continuing care unit or a group home that's funded possibly by DMH or by DCF, those kinds of complexities often get in the way of access, and not just on the acute care side, but oftentimes all throughout the continuum of care. And so I'm very honored to be moderating this panel. My first question is for the group. Given the access issues along the continuing for the kids with the most complex needs, could you each briefly speak to your work and how it touches on that group of children? And we can start with Dr. Sayah.
Thank you, Amara, and it's really a pleasure being here today. Thanks to MHA and Children's Hospital for putting this program together. It is about time, no question about it. You're wondering, what is an emergency physician doing here among such an esteemed group of healthcare providers and mental health providers? As an ED doc, everybody heard that when things go south, this is where the patients go. And over the last 30 plus years, I've watched dozens, not hundreds of, maybe thousands of adults and kids really in crisis come to the ED, to an environment that's probably not the best place for them. That's the only place that they can go and get their care. And I personally felt helpless because all I can do is stabilize the patient medically, keep them safe, and wait. And you all heard the wait is not the best thing. It's not in my nature as an ED doc to wait very long. Asking those questions, what can we do better? That's one of the reasons why I grew in healthcare environment to do what I'm doing today, because I've always challenged the system. How can we change things? How can we all change things? Over the last 30 years, I've seen a lot of changes, but I've never seen things as bad as they are in the last couple of years. But don't let the crisis go to waste. And I'm seeing an opportunity right now with this crisis that we're addressing it at all levels. We're addressing it at the legal level, we're addressing it at the laws, we're addressing it with programs, and we're addressing it with resources. And before I go on to what we're doing, I really want to acknowledge the tremendous work that the administration is doing in the Department of Public Health and EOHHS and many of our partners and advocates, both in the clinical community and out there that are in the room, with Secretary Sutters and the team at DMH, that really are taking this very, very seriously. And MHA has done great work to bring us all together and really shed a lot of light on this important subject. So what are we doing? The Cambridge Health Alliance is the only public health system in the state. What does public health system means? We are out there for the community. Our major work is in primary care and behavioral health. It's always been this, with a couple of small hospitals taking care of patients when they're acute. Most of our care is out there is in primary care and behavioral health. Our panel is about 130,000 patients. A good chunk of them are uninsured, underinsured, Medicaid. We have the highest proportion of underinsured and Medicaid patient in the whole state proportion. PMC probably has more numbers, but we have the highest proportion. And we have the highest proportion of undocumented immigrants and vulnerable populations. And our mission is to care for those patients, which makes those challenges even greater. You heard earlier from many speakers, particularly families that have resources and are having challenges. But imagine families that have no resources, have no place to go, have no insurance, can't speak English. Where are they going to go? They're going to end up in the ED. And we stabilize the patient, we keep them safe, and we wait. So in the last couple of years, based on this boarding problem I've been asking the question for 30 plus years, what are we doing about it? I remember my first meeting at the Consortium of Boston Teaching Hospital in 1990. We were talking about pediatric boarding in the emergency department 32 years ago, and I'm sure that question was there even older. And that question hasn't changed and hasn't been solved, and we need to solve it. I look at every ED visit for every child as a failure. Every ED visit for every child as a failure. It's a failure of the system, it's a failure of the screening, it's a failure of the prevention, it's a failure of the upstream work that we need to do before this kid comes to the ED. The real work happens before and after the acute hospitalization. I'm going to be talking about the hospitalization, but most of the work happens before and after. And we have to really double down on that work. So once the patient gets hospitalized, what are we doing about it? What we're doing about it is we're really doubling down on business that many organizations have shied away from, organization that historically does not pay. At work that is in behavioral health, that's not very high reimbursed. Patients stay there for a very long time. It's very resource needed, required, but it's important work. We have made a commitment to create the largest inpatient pediatric center of excellence in the state. That is at a hospital that we closed because of financial reasons in 2009. And we made a commitment to dust it off, really put a lot of resources in there, $52 million, to reopen it as an inpatient child psychiatry hospital that cares for child, adolescents, and most importantly, a 24-bed neurodevelopmental unit that cares for the highest acute patients in the state. And it's been a big challenge when you start with a hospital that's 60 years old, that's been closed for so many years, but we got through it. And over the last few months, we're slowly opening those beds. The staff there are amazing. They're doing God's work. I don't know how they do their jobs. I go there and walk through, and I'm like, oh my God, you guys are saints. And the care that's provided in those units is like nowhere else. I can't even imagine the work that they do every day. It's high-intensity care. There's a lot of providers there. They're all missionaries, not only healthcare providers and mental health providers. This is in their hearts. They were born to do this work. It takes a special person to do this work, and I really have all the respect for all of you in here to do this work because you were born to do this work. You are special. There's no question about it. And this is a commitment that we've made as an organization to really double down, as I said, on our mission. not only for child and adolescent, but also for adults and geriatrics. So when it's all said and done, we're going to have close to 160 inpatient beds for psychiatry. 69 of them are, as I said, child and adolescent. The work is not only for acute, and as I said, that most of the work is out there. We're out there in the community, partnering with many of you, making sure that the patient get their need out there. We run school health programs through Department of Public Health, teen clinics, and we work very closely in post-acute environment to make sure that those failures don't happen as much as possible, and there's a long way to go. Let me stop here. We'll have an opportunity to chat more with the questions and let my colleagues say their things.
Thank you, Attorney Marisol Garcia.
Thank you so much for finally bringing me out of the closet and letting everyone know that I'm an attorney, and you must be wondering what I'm doing here. Of course you're here. So I am Senior Director at the Mental Health Advocacy Program for Kids, which is I'm very proud to be the Senior Director of that program. It is a statewide legal services program that provides free legal representation for youth and families who are navigating these systems. I think one of the most tragic things I heard today was when Tashina said that after a medical intervention, she felt like a failure because as the good doctor was saying, the failure is in our systems. And 97% of the families that we interact with experience a barrier to care. And the number one barrier to care is a sweet little euphemism I like, which is called bureaucratic delay, which is that families are struggling to navigate these super complex systems, and without resources or support, it's almost impossible for them. The second one is incomplete information, which is families not even knowing that different resources are available. Our attorneys are based out of the Department of Children and Family Resource Centers that were created by the legislature. And those family resource centers are doing terrific things in the clinical space. They do have school liaisons, family partners, clinicians. They're working really hard every day to help families with basic needs like housing and other social determinants of health. And at the same time, we have an attorney in that space so that they can provide legal information for families on how to navigate these systems. The reason why we're here is because we do partner with emergency departments like Boston Children's Hospital in helping kids who are stuck in the emergency department because systems are not communicating with each other. The good news is we collect data on these interventions, on these legal interventions, and Boston University School of Public Health collects and analyzes that data for us and tells us that these legal interventions are working, that we're able to decrease inpatient psychiatric hospitalization and emergency department usage by significant numbers. Emergency department usage goes down from 44% to 14%, and no, that's inpatient psychiatric hospitalization, I'm sorry. It goes down from 44% to 14%. ED usage goes down from 70% to 23%. Because as so many people in this room are saying, the real work needs to happen in the community. And sometimes families really struggle to access those community-based services for all sorts of reasons. We have a lot of advocacy that we do in the school education space because that's where kids are. And then sometimes that's the first place that they're struggling, is to either follow the rules of school. I love that people are nodding. Thank you, Tashina, for nodding. That's where kids are struggling in school, either educationally or behaviorally. They're being excluded and suspended from school. And we have a special pilot that we're doing this year specifically centered on kids whose mental health needs are not being met, and how that creates creates a moment where many kids are excluded or suspended from school and then aren't able to get those therapeutic interventions from their individualized education plans that are supposed to be provided in school. We do a lot of advocacy on navigating state agencies, and we'll talk about that, I'm sure, more today, about how sometimes families don't have complete information about what they're entitled to through state agencies, or sometimes they're going back and forth between state agencies and ironing out some issues around insurance. But that's the legal advocacy that we do. We're really proud to be getting terrific outcomes even during what's easily the greatest public health crisis of our time. And I'm really excited about having this opportunity to talk to you about it.
Thank you. Melissa Threadgill.
Absolutely. So we've got a doctor, a lawyer, and sort of a general policy person. Perfect panel. So I work at the Massachusetts Office of the Child Advocate. If you haven't heard of us, we are an independent state agency that provides oversight of state services for kids. And we execute that mission in a couple of ways, all of which sort of involves trying to support kids with complex behavioral health needs. So at the individual level, we operate a complaint line. Families or really anyone else that has concerns about kids either not getting the services they need or that they're getting the services but it's not working, they can call our complaint line. We have trained clinicians that will speak with them and work to help them out. And many of the kids that come to our office have complex behavioral health needs. If you want to refer a kid, just Google Office of the Child Advocate. We've got complaint line all over our website. The second piece, and this is sort of forthcoming, but one of the pieces in the truly wonderful mental health bill that passed this summer is a forthcoming complex case resolution process. And the idea behind that is the stuck kids that Marisol talks about. Sometimes we really need to bring folks to the table to say, all right, what is the service that this kid needs? Do we have it? Who's going to provide it? Which agency is going to take the lead? Who's going to pay for it? How do we get it done? And so this process is going to be led by the Executive Office of Health and Human Services and the Department of Elementary and Secondary Education. And I know some information about that will be forthcoming soon. The OCA will have a seat at that table. We will attend every single meeting about these kids, and we'll be pushing to make sure that they get what they need. So that's wonderful work that's done by people that aren't me, by my wonderful colleagues at the OCA. I also want to talk just briefly about some of the work that we do on the systemic level, and that's sort of my role at the office, which is really sort of taking that step back and saying, are kids getting what they need from the state government? And so we do that through research, we do it through data analysis, we convene stakeholders, and ultimately we get to make recommendations to the legislature and the executive branch on ways things could be different. And so I just want to highlight one piece of work that we're doing right now that I think is really relevant to kids with complex behavioral needs. And this is a study of the Child Requiring Assistance System. So for those of you that may not be familiar with that system, this is a court process that families or schools can petition the court to say, we've got a kid that requires assistance. Sounds really benign, right? The types of cases that come to the court from schools are if there's sort of habitual truancy or what's called a habitual school offender. These are kids that are not following school rules habitually. Parents can petition for what's called a stubborn child. Yes, this is in our Mass General laws, stubborn children. Most of these kids are kids with behavioral health needs, where they're not listening to their parents or they're running away a lot. And so we see a lot of kids with complex needs that come to this court process. These kids have significant trauma histories. Many of them have previous care and protection involvement, and that it's manifesting in aggression. It's manifesting in really poor decision-making sometimes, running away, school refusal. So the goal of this study, and we'll be having a report coming out sort of late November, early December, so stay tuned. But the general spirit of our findings is that families are coming to the court system absolutely desperate. But the court system is not set up to provide them what they need. And that's no shame on the juvenile court system. Probation officers and judges are not mental health clinicians, right? And so we put these kids into a court process, which is incredibly traumatic. You're dragged into court, you're in front of a judge, you're more or less told you're a bad kid, right? The judge won't say that, but why else are you in front of a judge, right, if you're not a bad kid? It's damaging to kids, it's damaging to families. And the reason that they end up there is because they didn't have the luck to work with Marisol's team, and they're just looking for help. Right? Families shouldn't have to petition the court to get services and systems, and we'll be making recommendations to try to make that more of a reality. Thank you.
Thank you so much. So I'm going to try to get through these next questions fairly quickly. I will start with you, Melissa. So how do children with and you talked a little bit about this, but how do children with the most complex needs currently come to the attention of state agencies, and how should we think about reimagining that?
Yeah, absolutely. I've got three basic ways. First one is the one I'd call the good one. A family says, I need help. All right. Maybe they come to a family resource center. Maybe they talk to someone at their school and they help them figure out a DMH application or a Department of Developmental Services application. But a family says help and the state says, yep, we're here to help. That's great. That's how it should be. two other ways that kids with complex needs come to our attention. One is we already knew about them and their needs got worse under our watch, right? So these are many times kids that are in the custody of the Department of Children and Families, right? They start off as younger. Again, if you're involved with DCF, you have a trauma history, right? You've got some needs there, and the needs get worse over time, right? And so we already knew about these kids. We just watched them have their needs become more complex. And then third way I just spoke about, which is the court process, right? So both the child requiring assistance system or the delinquency system, right? Which is a kid has behavior that would be criminal if they were adult, and now they're in front of a court process. And again, we're telling them they're a bad kid. A lot of times we see kids with really significant mental health and trauma histories that come to the system that way.
Thank you. Marisol, you are an attorney. It's no secret anymore. Why do you think your expertise and other, the law and attorneys, why do you think they should be a part of sort of the solution to reducing barriers to care?
Thank you so much. I think so much of what Melissa talked about is true, which is that often kids with unmet mental health needs end up in the juvenile court. We know that 80% of the kids involved in the juvenile justice system meet the criteria for a mental health diagnosis. And so our organization also collects data and knows that about 30% of mental health clinicians are advising families to bring kids to court. When BU told me that, I didn't understand it. And what they basically explained to me is that you all don't know how to navigate the system either, right? Pam Sager is saying, like, I was a lawyer and I had a hard time navigating this system. I mean, you really need expertise, legal expertise, and families with means are accessing that legal expertise. So our families that are marginalized, our families of low income, they're having an even harder time navigating the system. And most of the families that we're interacting with, they're the parents and have mental health needs as well, because we know that in the data. So we have parents who have their own mental health issues with children who are boarding in the emergency department or struggling in other ways. And so really, a lot of these systems are set up in a way that are very challenging for someone without that expertise to access those mental health services. And that's the way that we see. I've been asked the question, why lawyers, for a long time. And I'll tell you, it's really the place where we're seeing the results is because we do have the legal expertise to enforce entitlements that families have under the IDEA, and to read the regulations and figure out how families are eligible for different benefits through state agencies and other organizations.
Thank you. And Dr. Sayah, CHA has recently made significant investments in the pediatric behavioral health space, particularly your new neurodevelopmental unit. What would you say was the greatest hurdle that you had to overcome to make that happen, and how gratifying? What was also been the most gratifying?
Where do I start with hurdles? It takes a commitment at the beginning, and it takes partnership. This is not something that one person or one organization can do, but it's absolutely something necessary. And the greatest challenge, and the hurdle is at the beginning, as I said, with the commitment and with the resources and with funding and just making a decision to do it. But the greatest challenge, and this is something we're discovering, is once you build it, you got to make sure it works. And this is new work. We've seen some of those patients, but not to the level of acuity that these kids have. And these are the sickest of the sickest. These kids that are autistic, many of them nonverbal, very aggressive, big kids. Very difficult to communicate with and manage, and we need to create an environment where they can improve. This is not an environment where the answer is chemical and physical restraints. That's not what we want to do. And initially we said, okay, this is going to be great, 24 unit, 24 beds. We're going to get a lot of kids. After the sixth kid, we said, stop. We need to sort of rethink about this. And because there were a lot of assaults, to the staff. We lost probably 90% of our staff in the first, we turned over 90% of our staff in the first 4 or 5 months for various reasons. And many of our staff are experts, and these guys are not fresh. So we started working on the basics, on the programs, on the physical plan was absolutely great. It was well planned, making sure that we predict things and foresee things, and we have plenty of people around the child, and make sure that, programmatic-wise and safety-wise are very important. So now we're still learning. We also visited other programs that have gone through this, and we're not new at this. The more we ask, the more they say, yeah, you're not the only one. Everybody that's done this went through these growing phases. But what is rewarding is really seeing these kids thrive. A couple of the kids were written off, and we see them blossom. It took weeks. It took months. It took patience. We have a child who's a teenager who's twice my size. That's not easy to be, but anyways, it's not hard to be. At twice my size, who was on the unit, who was completely aggressive. He assaulted 2-3 people, and this is a child a few weeks later who is learning, we're working on getting him to a residential school. That was not even possible, a few weeks ago. This is what's rewarding about this. It's the one-offs, it's the work that we need to do. But as I said, early interventions, the majority of the important work happens in your area, and after we get this kid out, hopefully to a residential school, and they thrive out there. So we don't want to see him back.
I think that's a good note to end this panel on. I just want to thank you all for joining us today for this event.
Thank you. I appreciate it.